Thank you, Dr. Nagraj, for joining us today on this World Cancer Day month. And we are organizing and doing activities this entire month on this occasion, so that we are able to increase reach of the impact. And जैसे कि आपको बताया, वर्ल्ड कैंसर डे 4 फरवरी को मनाया जाता है सबके लिए। एंड हम लोग एक इम्पैक्ट सीरीज कर रहे हैं जिसमें एक कैंपेन शुरू किया है 1 लाख लाइव्स इम्पैक्ट, जिसके अंदर हम 1 लाख कैंसर पेशेंट्स को फ्री ऑन्को न्यूट्रिशन प्रोग्राम सपोर्ट प्रोवाइड कर रहे हैं। यस डॉक्टर।
Yeah, that's right. Thank you. So tell me, thank you so much for inviting me. You tell me when I should talk, and then I'll talk.
Right, doctor. Right.
Yeah, should I go ahead and talk?
Right. I'll introduce Dr. Nagraj now. Dr. Nagraj is a world-renowned radiation oncologist with more than 43 years of experience. He has published around 100 papers in national and international journals and edited 3 books related to cancer. He is the founding member of Society for Cancer Research and Communication, and also the member of American Society for Therapeutic Radiology and Oncology, Radiation Research Society USA, and European Society for Hyperthermic Oncology. Dr. Nagraj was also honored with Haldar Memorial Oration by Association of Radiation Oncologists of India in the year 2010. He has also been felicitated with Citation and Lifetime Award by Indian Medical Association on Doctors' Day 2013. Very well-renowned, and personally, I'm very inspired by doctors' knowledge, humility, empathy for patients, and also support that he gives to the youngsters who wants to do something meaningful and impactful in this field. So thank you so much, doctor, for joining us with sharing your knowledge, experience, and expertise with others. So हम लोग कॉन्वर्सेशन ट्राई करेंगे कि हम हिंदी में रखें ताकि ज्यादा लोग समझ पाए। एंड हम रेडिएशन थेरेपी के साइड इफेक्ट्स, रेडिएशन थेरेपी कितने प्रकार की होती है, एंड उसके हाइपरथर्मिया के अराउंड कुछ क्वेश्चंस हैं जिससे हम शुरू कर सकते हैं। डॉक्टर आप भी शुरू कर सकते हैं। थैंक यू।
Okay, thank you, Ms. Dimple. And what we can do is we can make it more conversational, and if there are questions, I can answer. So let me begin by saying that radiation oncology, which started more than 100 years ago, and if you compare with surgery or many other modalities of treatment, it's a very new form of treatment. So there were a lot of myths, like say for instance, 40 years back when I started radiation therapy practice, the machines were not so great. They were, but not as sophisticated as they were here today. And everybody thought that if radiotherapy is recommended, that's the end of life. Now, a lot of things have changed in 21st century. In 2024, we are riding the crest of technological innovations. You name it, it is there, and every day something new keeps happening. So it's many times it becomes very difficult for people to understand and choose from various modalities of treatment, and they get confused. And there's a bit of a kind of a marketing, if you wish. आपके पास B mat है, R mat है, S mat है, whatever, they read in Google, and then sometimes they get waylaid, and if people find it very difficult to choose because now there's so much of choice, right? Maybe if people want to ask any questions regarding various techniques, that'd be nice. Otherwise, I can just tell them what are the things that's happening. Are there any questions?
Right. Yes, डॉक्टर, एक क्वेश्चन है कि रेडिएशन थेरेपी में कई सारे एडवांसमेंट्स आए हैं, जैसे कि प्रोटॉन थेरेपी है और भी टाइप की थेरेपीज है। तो पेशेंट जानना चाहते हैं कि उनके लिए बेस्ट रेडिएशन थेरेपी प्रोसीजर क्या रहेगा, या फिर उसमें भी बहुत सारे ऑप्शंस होते हैं। तो कैसे हम डिसाइड कर सकते हैं एज ए पेशेंट या केयरगिवर कि हमें कौन से प्रकार की रेडिएशन के लिए जाना चाहिए, या फिर ये डॉक्टर्स का ही डिसीजन होता है और हमें वो करना चाहिए?
Yeah. That's what I was saying. There's so much of technological advances. So briefly, let me tell you this. Now, there is something called an external beam radiotherapy with photons, internal or intracavity radiation therapy with photons. ऐसा है brachytherapy जब हम बोलते हैं. Now brachytherapy का role is like cervical cancer में है या कुछ कभी-कभी head and neck cancer में है, prostate में है. लेकिन उसका यूज आजकल थोड़ा सा पहले कितना था उतना है नहीं है, वो काफी कम है. It's far less than what it used to be before, and there's a reason for that. First of all, it's an invasive procedure, and it's if the tumor is very large, you cannot really do a brachytherapy. So cervical cancer, you don't have to do any major surgical procedures. It's like DNC, and you put in a tube inside, and you can do cavity very easily. So most of the innovations have happened in external beam radiotherapy. As I said, photons. Photons are nothing but X-ray. Like what you have in a CT scan or X-ray are also photons, but they have very low energy. So when it comes to radiotherapy, we have very high energy photons of radiotherapy, and they're very fast. As a result of which, we can treat the patients to a very high dose or the required dose very, very quickly. What used to take sometimes 2 to 3 hours in the 30s, now, and I mean, I'm talking at the very beginning, now I can finish in 2 minutes or 3 minutes, flat, and much, much more than before without any pain, and they're invisible, so on and so forth. Now, in the last 20 years, there are various techniques that have emerged. One is called intensity modulated radiotherapy. Now, when we talk of intensity modulated radiotherapy, which has, almost became very popular in the last 20 years, of course, the concept came much earlier, is I keep telling everybody to think of the Rangoli patterns, the colorful patterns people do, like column or something. It's in Kerala that you do, or others. The various pictures emerge with the different colors. What do? You have different colors, different intensities, to different volumes or different areas. So the same thing is done in intensity modulated radiotherapy. Now, of course, I don't have pictures to show you. Let's take, for example, chest. It's very easy for all of us to understand. In the chest, we have heart, we have lungs, we have spinal cord, we have esophagus. That is food pipe. Now, suppose if I go to treat the food pipe, I've got to give maximum radiation to the food pipe and much, much, much less to other areas. Now, earlier on, even when we did what we call as a three-dimensional conformal radiotherapy, a lot of normal tissue was getting involved, to a higher dose. Now with IMRT, what we can do is the volume may be more, but the intensity of radiation or the quantum of radiotherapy goes down to the normal tissue. So as a result of which, you can really give a lot more radiotherapy to the primary or the cancer than ever before without damaging the normal tissues. So when patients come to me, and naturally so, everybody's concern is what will happen to my normal tissues, right? And many people don't realize that when the surgery is done, that even during the surgery, you go through the normal tissue and then reach the tumor and then take it out. The same question is never asked during surgery, but it's a legitimate question. Having said that, normal tissues have an enormous capacity for repair, Even if they get damaged a little bit, they get repaired much, much, much faster. But unfortunately for us, the cancers cannot repair themselves so quickly or so efficiently. So there are various reasons for that. Having said that, that's not so relevant now. So there is a differential. So for we give a high dose of radiation to cancer, much, much lower to the normal tissue. Normal tissue can heal faster, and the cancer tissues don't have that capacity, so they die. And now that with IMRT and many other techniques, we can give very high dose to cancer without giving similar dose, escalation of the dose to normal tissue. We can increase the total dose of radiotherapy delivered very safely, and thus increasing the survival or increasing the cure rates or response rates. So that's about IMRT.
Got it. Thank you, Doctor. आपने
Okay.
से explain किया. एक question है कि can you throw some lights on proton therapy for adenocarcinoma that is spread to brain, and also how good is it for lungs? Also, any inputs on FAPI therapy?
What therapy?
FAPI.
I really don't know what is the FAPI. If you can expand that, it's okay. All right.
It says fibroblast activation protein inhibitor.
Okay. They're highly, they're targeted therapies. Yeah, they're injectables. So you've got to have, in a certain, like I think they are talking about the adenocarcinoma. It's relevant in that context. It's mostly handled by the medical oncologist. I'm sure they can expand more on that. Now, having said that, adenocarcinomas of lung, once upon a time, we thought that like say for 30 years or 40 years before, the moment we had adenocarcinoma, then we said that's the end of the road. But today we have innumerable treatment. Just because an adenocarcinoma, it does not mean that radiotherapy cannot be given or need not be given. It's none of that. So adenocarcinoma is not, it's complex. There are many other subtypes. There are different molecular profiles. There's EGFR, ROS, ALK, BRAF. So many subtypes, and of course PDL1. So the medical oncologists now have come up with an immense armamentarium of medications, right from targeted therapies to immunotherapies, and of course the chemotherapies. Now coming to brain, it depends whether it's a solitary lesion, multiple lesions. Just because an adenocarcinoma, it does not mean that radiotherapy is not given. If it's a solitary lesion or what we call an oligometastasis, where 2 or 3 close, wherein we can treat all of them, we can do what we call as a stereotactic radiotherapy, wherein you give a very high dose of radiation to only those areas within the brain. Now, that seems to be gathering a lot of acceptance in the last 5 to 6 years or 10 years. Probably it's very useful. The main reason as to why we started with stereotactic radiotherapy is the fear that with radiation, whole brain radiotherapy, there can be a loss of cognition. Now, in my department, even when I do a whole brain radiotherapy, I routinely do something called stem cell sparing or hippocampal sparing. And that really helps. So there are indications wherein you should go for whole brain radiotherapy with simultaneous integrated boost or without that. And if it is amenable, the lesions are small, even if there are few and multiple in and around, wherein, it all depends on the technique and technology. And again, when it comes to this kind of a radiation, don't get carried away by the names like cyberknife, gamma knife, this knife, that knife, etc. And these days, most hospitals which have reasonably good linear accelerators are capable of doing SRS. We are not here talking of very minute lesions of like in AV malformation, but cancerous tissues. So don't get carried away. But people come and ask, how about cyberknife? Cyberknife is the name of the machine. It does the same thing. Okay, so gamma knife. It was first gamma knife was 1951. People think it's something very new. It's not that. Again, very interesting approaches to SRS, but now almost most of the contemporary linear accelerators can do stereotactic radiotherapy. So that should not be a problem.
Right. Thank you, doctor. This one question. Radiation therapy के बाद में side effects होते हैं, जैसे यूरिन में जलन होती है, मेमोरी लॉस होता है, स्किन बर्न होता है, सलाइवा नहीं आता है या फिर बहुत ज्यादा आता है. तो हम ऐसी क्या चीजें कर सकते हैं जिससे कि साइड इफेक्ट्स कम रहे, और अगर होते हैं तो हम उसे कैसे मैनेज कर सकते हैं?
Okay. Now, again, it's a good question, but as I said, and as I always tell my patients, there is nothing in life which is without side effects. You eat more, you have indigestion. You got to reach somewhere, the traffic can kill you. They are all side effects of doing something, right? Similarly, there are side effects, much like in chemotherapy, much like in surgery. Now, let's take one by one. Let's take, say, for a dryness of mouth. Now, dryness of mouth is very common when we are treating oral cavity tumors. Intensity modulated radiotherapy, which spares the parotid, has managed to, we have managed to decrease the dryness, either the frequency or the quantum of it, by sparing the parotid during the treatment, which was not possible in the earlier eras. So we do still find certain amount of dryness. So what we do need to do is we got to have oral hygiene maintained, fluoride prophylaxis before radiotherapy, and if necessary, we can have a saliva substitute. And sometimes, if it is bad, earlier on, I started trying hyperbaric oxygen, and then we have, every physician has his own approach, and every patient has his own approach. If there is dryness of mouth, oral hygiene is very important, and use saliva substitutes, maintain pH, and so that's right. And there's some, some high dose vitamin E, selenium, and they're all tried but not necessarily proven. That's, for instance, dryness of mouth. Let's talk about the memory loss. Now, the memory loss very often is due to the disease itself than due to radiation, but it can happen, much like, say, for instance, methotrexate. Now, if somebody is combining radiotherapy with high dose of methotrexate, that's the tunnel lymphoma, this is really a bit of a scare. So, what we started doing in my department is to do what we call as a stem cell sparing. It may be effective, it may not be effective, maybe it's effective up to a point. And recently, there's a drug called Mementin. We have started adding. It's for Alzheimer's and all of that. So we have started using that in post-radiation patients for memory loss. And say, for instance, burning. You start very simple with barley water, use barley water, potassium substitutes, coconut water, and then all of this the incidence and the frequency, etc., can be reduced by good planning of radiotherapy, good fractionation, good planning, and choose the right patients. Now, if you're trying to choose a very big prostate or a cervical cancer, when you combine chemotherapy, these side effects are a little more. We need to have a very smart planning, and then all these supplements to ensure that side effects are less. In the worst case scenario, sometimes I also recommend what I call as hyperbaric oxygen, 20 to 30 sitting sessions. It helps. It helps. Okay.
Got it. Right, doctor. A question है hyperbaric oxygen पे. What is the best period for hyperbaric oxygen therapy?
See, with the best, hyperbaric oxygen has been used in the past as a radiation sensitizer, which means you gave hyperbaric oxygen almost simultaneously. The purpose there was to sensitize hypoxic cell tumors to radiation to increase the effectiveness. But the kind of hyperbaric oxygen therapy that we are talking here, very often, which can be up to 30 to 40 sessions, almost daily, 5 times a week or 4 times a week, is when we are stuck with, say, for instance, post-radiation cystitis, post-radiation proctitis, or esophagitis, essentially delayed post-radiation sequel due to inflammation of the soft tissue. That is the time when I recommend hyperbaric oxygen, and there's some evidence that hyperbaric oxygen can make a considerable difference.
Wow, that's really great. There's a question. My husband's radiotherapy was done in April 23, and he has started stiffness in neck in October 23, which is after 6 months. Now his jaw movement is restricted. Can we do HBOT now?
So this is called trismus, and basically, jaw stretcher, exercise, etc., are far more effective than anything else. But there's no harm in doing HBOT because it's a very safe procedure. But then again, there's not much of a clinical proof to say do it or not to do it. But I personally think there's no harm in doing it. But jaw stretching exercises are far more important than anything else, and may also make certain that to get an appropriate scans to make certain that there's no recurrent disease there.
Okay. Thank you, doctor. In case lesions come back, can radiation be given in brain again? It is
Yeah, again,
Yeah.
yeah, sorry. It depends on the interval. I mean, if something comes back progressive within 2 to 3 months, then it becomes very difficult. So, say for instance, that if I have done an SBRT, yeah, which is a very, very, very small volume of radiation. Yes, I mean, if it is further away from the original field of radiation, we can SRS. So we can definitely do an SRS. So there are guidelines, there are rules and regulations. But the whole objective is see that you don't make the patient miserable because of the treatment, right? So it must be far more effective. And if the interval is more than 2 to 3 years, no matter what, I'm sure you can give it even in brain. And the approach should be different than at one from the first one.
Understood. Right. And how do we personalize radiation therapy for individual patients, type and stage of cancer? So, what all factors usually doctors consider when they personalize radiation therapy for patients?
So first of all, you've got to decide whether radiotherapy is necessary or not, depending on the stage. And what is that we are looking at? Is it palliation? Is it cure? Is it symptomatic management? The aim of the treatment is very, very important. Having said that, then also you look, say for instance, somebody with 90 plus, frail, debilitating, where there's no tomorrow. There's no point in giving radiotherapy or any other treatment.
Yeah.
So, but if the same thing happens to somebody with 60 and 70, the approach will be different. So the comorbidities, age, sex, what is the objective, stage. Unlike in medical oncology, where now some of the molecular markers are emerging, molecular markers, we don't have any predictive molecular markers, but there is a lot of image-based predictive assays which are coming up, like texture analysis. I published on paper recently on that. So it's essentially very old-fashioned, age, comorbidities, extent, objective, feasible, not feasible, and then should we do it or shouldn't we do it?
Understood. Okay. डॉक्टर पेशेंट्स एंड केयरगिवर्स को अपने आप को मेंटली कैसे प्रिपेयर करना चाहिए रेडिएशन थेरेपी से पहले?
क्या करना चाहिए?
उनको वो मेंटली अपने आप को कैसे प्रिपेयर कर सकते हैं रेडिएशन थेरेपी के पहले?
Mentally, now I have, it's what is the reason for fear? The fear of anything, and now in this case, radiotherapy, it is because of two reasons. One is that we have heard a lot of stories, the negative stories, one. And secondly, we don't know what is radiotherapy. That's lack of knowledge. These are the two things which make people very fearful. And people then hence avoid the treatment itself. They come back when it all grows and becomes unmanageable. So the first thing is, if you have collected a lot of myths about radiotherapy, be it painful burns, you lose eyesight, you lose hair, all those things that you heard, first go to a specialist or a counselor and sort that out. So when you're doing this in the process, try also and understand what is radiotherapy. I think here in people like you, Ms. Dimple, are very relevant to extend and then communicate with these people what is the nature of different modalities, including radiotherapy. And so it's talking to the right people, getting over the myths, and getting over the fear by gaining appropriate information or knowledge about radiotherapy. And it could be true for anything else. Radiotherapy in this case, because we're talking about radiotherapy.
Understood. हमेशा ज्यादातर fear लोगों को side effects का होता है और वो सोच के ही कि ट्रीटमेंट शुरू हो रहा है तो क्या होगा, अंदर से सुना है कि साइड इफेक्ट्स होते हैं, बॉडी अंदर से जल जाएगा, ब्लैक मार्क हो जाएगा साइड, तो वो सोच के और साइड इफेक्ट्स की उनकी काफी बड़ी रहती है। बट आजकल जो व्हाट आई एम हियरिंग आल्सो फ्रॉम डॉक्टर्स दैट बिकॉज ऑफ टुडेज एडवांसमेंट टेक्नोलॉजी, side effects are very less or minimum and that can easily be managed by taking proactive actions. So
Yeah.
yeah.
Yes, that's right. And I think it's here in the role of counselors, the trained counselors is there. And many people go into a reactive depression. So, psychologists, counselors, psychiatrists, all of them upfront, if they get involved, it's very nice and make certain that patients talk to the or relatives talk to the right people. And sometimes even the patients who have gone through it, the survivors or may not be the best people. I'll give an example. There was this lady, I still remember, she wanted to be a counselor. But then again, I realized that she had a very bad experience with her mother-in-law. Now, she would transfer her anxieties and her problems that she had with her mother-in-law during the treatment to other patients. So, just because somebody has survived did not necessarily mean that they are the best gurus for you. So you've got to go to a properly trained counselors and who are empathetic, who are knowledgeable, and they can make it so much easier, so much better for everybody, including the patients and patients' relatives.
Thank you.
Unfortunately, we don't do that routinely. Yeah.
Thank you, doctor, for sharing that. एक क्वेश्चन है कि हाइपरथर्मिक ट्रीटमेंट क्या होता है एंड वो रेडिएशन थेरेपी के साथ कैसे वर्क करता है, सो व्हाट इज हाइपरथर्मिक ट्रीटमेंट एंड हाउ डज इट इंटरेक्ट और वर्क विद रेडिएशन थेरेपी, एंड इफ वी कंबाइन बोथ थेरेपीज देन व्हाट आर द बेनिफिट्स?
तो hypothermia, unfortunately, hypothermia इसका मतलब यह है, this is to heat the tumor to 41, 42, or 43 degrees Celsius. Now we have a couple of machines. One in which I've made published my literature, or I've treated more than 2,000 patients with hyperthermia and radiotherapy. It was on a radio frequency based external heating system. In fact, we are trying to come up and plan and design hypothermia machine for Indian use with IIT Madras and Samir in Mumbai. Samir is a radar-based Government of India consortium. So hypothermia, how does it work? It like we were talking of hyperbaric oxygen. In the same way, hyperthermia can increase the blood supply, increase the oxygenation, and hypothermia in itself can inhibit repair. Inhibit repair, and not only inhibit repair due to radiation, but it can also inflict what we call as single strand breaks and double strand breaks in DNA. Having said that, it can also work on cell membrane. Now, radiotherapy or ionizing radiation doesn't affect the cell membranes. So what hyperthermia or heating makes is, now in a cell membrane, there are a lot of fats. Now imagine boiling your ghee. So when you boil ghee, when you heat ghee, it all melts, right? And in the same way, the cell membranes in which there are a lot of lipids, once you cross the temperature of 42, 43 degrees, they become leaky. They don't melt like the ghee, but they do, become leaky like the ghee, it would be less consistent, so on and so forth. So it has its own impact on the intracellular metabolism. So hyperthermia is best combined with radiotherapy and, of course, chemotherapy as well. One which has become very popular in our country is what we call as a HIPEC. HIPEC is intraperitoneal chemotherapy. So that seems to have become.
Hi, doctor.
After the surgery, chemotherapy at a high temperature of 43, 44 is instilled in the peritoneum. So that's a different thing as well altogether. So when we talk about hypothermia, now we have microwave-based machines or radio frequency-based machines. Not easily available in India, but there are not many centers who took it up. We did. Now I'm not doing it anymore because we need to buy a new machine. We're trying to make it popular. Yeah, that's how it works.
Okay. Thank you, doctor, for sharing the difference and availability as well. क्वेश्चन है कि इंटीग्रेटिव ओंकोलॉजी एंड होलिस्टिक ट्रीटमेंट पर आपके क्या व्यूज हैं, जैसे मेडिकल ट्रीटमेंट के साथ कॉम्प्लीमेंट्री ट्रीटमेंट कंबाइन करने, न्यूट्रिशन और योगा, मेडिटेशन और इंटीग्रेटिव थेरेपीज, सो उसका ट्रीटमेंट पे, उसके आउटकम्स पे क्या रिजल्ट होता है, आपके थॉट्स क्या हैं उस पे?
See, when I say holistic, yes, holistic is like as I talked about, involving the counselors, even if you want your priest or psychiatrist, a nutritionist, everybody on board is what I mean by holistic. Now, generally, what I tell my patients is not to use the herbal medicines or non-herbal medicine along with radiotherapy because I don't know how they work. Okay, and many a times somebody comes with a pill and we don't even know what it contains. Some of the herbs that I know, I've studied. If I come across that, I said, okay. But however, I have no problem because it's always the patient's choice. I have no problem if the people use it after I finish radiotherapy or a definitive treatment is completed. Uh, this is something like this. Only today, a young man for 4 or 5 months, early lesion treated on herb-based medicines, wherein it should have been operated. So now it's a big tumor. There are failures in every branch of medicine, every approaches. But we know, suppose if I say, okay, 60% outcome, I don't know the same kind of statistics with other ones. But once I'm done, it's the patient's prerogative.
Right.
So I won't come in the way. No.
Understood. Right. Got it. There's a question, doctor. Can radiation therapy be combined with other forms of cancer treatment?
Yes, we do. We do. Now, say, for instance, when I say post-operative radiotherapy, that means you're done after the surgery. You do pre-operative radiotherapy, or you do chemoradiation. That means chemotherapy with radiotherapy, or immunotherapy with radiotherapy, or hypothermia with radiotherapy. Cancer treatment is always multimodality, either in sequence or simultaneously. So it has to be with everyone on board.
Got it. And if are there any long-term side effects that cannot be reversible in this case?
Yes, that especially these days, but we're giving what we call as hypofractionated radiotherapy or stereotactic, etc. The soft tissue changes. Say for instance, I've treated leg for soft tissue sarcoma. It can become stiff, or even the breast sometimes become, very stiff or indurated. The cosmetic outcome may not be so good. Or in a very small percentage of the patients, say I'm treating prostate or cervical cancer, there can be, 1% or 2% very bad cystitis, that is, the bladder gets affected or a rectum gets affected. But that's a small percentage of patients. See, anything and everything has a side effect. Some of them are, but it is less and less and less and less. We got to analyze cost benefit. The benefits are far, far more than the side effects. But we should discuss the side effects. I'm not saying we should not discuss the side effect. We
Right.
should, but it should be kept in mind that it's mostly a lot of good effects, and it's sometimes it's like getting into crowded bus.
Right. And there's a question like patients, when they want to start the radiation, a doctor may not always have time to explain in depth about the potential side effects and how to resolve those side effects. So
Go
who
to a
can
different doctor.
Sorry? Okay.
Go to a different doctor. And I'm joking. And no, you got to have a system wherein, somebody sits, maybe the nurse, maybe some oncology nurse, or other counsel, somebody. It's very important for you to understand the side effects. See, I understand, like for places like very busy places, Taj Mahal Hospital or Kidwai Hospital, there are hundreds and hundreds of patients. It may be very, very difficult to spend time for the doctors, but we must create a system where it's not so difficult. Yeah, or people must be encouraged to access various sites apps these days, where they can go there, access them, learn about them. But it's just that at least we should tell the patients, give the reference, otherwise they get lost in the net.
Right. Okay. Thank you. There's one question. How do genomic profiling and biomarkers influence the customization of radiation therapy for cancer patients?
Now, I told you a while ago that we don't really have great markers
Okay.
as of today for radiotherapy, but of course they are in the medical oncology because they're in, they are receptor specific or gene specific. You have designed the drugs like that. As I said, similarly there are certain uh, genes for repair. They're called repair genes. So people are trying to see if we can harness them uh, to pick up the patients for treatment. There is something like what we had, it has not become very popular. It's called texture analysis. So we did that to predict in hyperthermic radiotherapy. There's a lot of work that's being done. So to predict or predictive assays, either image based or molecular profile based, and one which is being pursued very actively is repair genes.
Right. Okay. And there's a question when we talk about palliative care. Sometimes palliative radiation is given. So, what what is the role of radiation therapy in palliative care, especially in terms of improving quality of life for terminal cancer patients?
Oh, yes. I mean, the palliative radiotherapy plays a big role and a big part of anybody's practice as well, especially in pain management, uncontrolled hemorrhage, yeah, and obstruction. Suppose there is SVC syndromes. All of this, and it can be very magical, in fact. Yeah.
Okay. Right. And when palliative care patients are already going through the palliative phase, and during that time when we give radiation, will it also have side effects because their condition is already not good?
Yeah, so you got to just give a smart and appropriate radiotherapy, wherein side effects become so irrelevant that it's the effect. Like, say, for instance, I'll give an example: SVC syndrome. Now, here is the man or a woman comes with breathlessness; they cannot sit, lie down, anything. So, with three fractions of radiotherapy, large fractions, within third, fourth, or fifth day, they start breathing. They're happy. So, if you can make them happy without any major side effects for next few months that they're alive, that's indeed magical.
Yeah, yeah, yeah. Thank you. Yeah, that's true. We have to do the analysis. If they are getting immediate relief, then that's more important. Otherwise, every minute is very struggling to survive. Right. There is a myth or a question rather. Will I be radioactive after receiving radiation therapy? Is it safe to be around family and friends?
Yes, it's always safe. No
Mhm.
problem.
Right.
Only when the PET scan is done, they inject radioactive sources. So whether few, they're advised not to be with 3 or 4 months. One. And there was a time, or if there is there's something called a radioactive iodine. Now,
Right.
some people do a radioactive iodine implants,
Right.
especially in prostate, etc. It's not popular in India at all. So if that is done, you've got to wait for 3 or 4 half cycles for a intimate relation. Otherwise, it's fine.
Okay, right. And I think the last two questions, doctor, there's a question which says, are there any particular type of cancers where radiation therapy is most beneficial or seen higher success outcomes, or it's same for all type of cancers?
I think it's safe and effective for almost all kinds of cancer. But say, for instance, there's a belief that something like a melanoma, which is luckily we don't see many of them, is far more resistant to radiation. So then you may have to approach melanomas in a different way. So that's why when it comes to melanoma, you operate first and radiate. So there are some few types of cancers like this which may not be as sensitive as other cancers like epithelial cancers or lymphomas and so on and so forth. So, uh, by and large, most cancers are amenable for radiotherapy.
Mhm. Understood, right. And the last question is, the second last question, can radiation therapy affect fertility or cause long-term health issues?
Yeah, fertility can be affected if we treat cancers in and around the genitalia. Like, so say for instance, if I try to treat cervical cancer, so there are certain ovarian oophorepexies. Say somebody comes with a very early stage cervical cancer, we want to treat the but at the same time retain the fertility. So you can do oophorepexic, that is move away the ovary surgically away from the side of radiation, or protect up to a point the testes to an extent. But if we are talking of radiation away from these areas, it will not affect fertility. So, but it's a good question. It's very important that in that case, you've got to either have a spawn, cement banking or ovarian banking. You must harvest them and bank them.
So all patients should go for this banking, or only in the affected areas they should go?
Yeah, not everybody. Only when we're treating that affected that area.
And what happens if I miss a radiation therapy session?
No, I mean, that's what I'm saying. I mean, you just one cycle of, say for cement banking is not a big deal, but we're talking about OOMs, yeah, because one cycle it gets delayed for maybe 10 or 15 days because you've got to induce them and then harvest them. So 10, 15 days delay, that's okay. I mean, I think there are various reasons. Yeah, but especially if the fertility is the question in mind, you must think of that, and those facilities are available in most major cities. Most major cities.
And in between the cycles, if patients are missing any one cycle of radiation, is it okay to miss, or
It's a difficult question to answer. Generally, not.
not? Okay.
I mean, if somebody has received radiation already, uh, because there is no threshold as of the current model. Okay, it's called linear non-threshold model. So if you're going to go with that, there is it's a little risky.
Okay, understood. Thank you so much, doctor, for very patiently answering all the questions. And thank you for your knowledge, sharing knowledge with us and dedication to advancing cancer care. All the attendees, thank you for engaging questions and being part of the discussion. Doctor, really appreciate you taking your time out on this day to share your experience and answers with us. And we wish everyone health, wellness, and strength on our path forward. Thank you so much.
Thank you on this World Cancer Day. I hope everybody gets cured, everyone heals. God bless everybody. Thank you so much.
Thank you. Thank you so much.
Thank you.